One a few weeks ago on privacy and security. This one is on common data elements, and we hope to continue these webinars both to keep you updated on things on progress on BrainCODE, but also we may have subject-specific webinars like this one and the last one, privacy and security and common data elements. I wanted to thank you because a lot of you have been involved on the activity and establishing the common data elements for BrainCODE. You've been very helpful throughout this process, so thank you for that. I will start us off. I'll give an overview of BrainCODE, and then I'll pass it over to Anthony. Anthony Vaccarino is a member of the Indoc Consortium, and they are the consortium that's building BrainCODE on OBI's behalf, and they've been really leading on the common data elements work and doing a great job. So an overview of what the integrated discovery system looks like and how BrainCODE plays a role here is that we've got 5 programs plus 2 pilot programs. So the 5 are cerebral palsy, epilepsy, neurodevelopmental disorders, neurodegeneration, and depression. And then we're giving pilot funding to addiction and concussion, traumatic brain injury. Each one of the programs have multiple sites, lots of different data sets coming in, different types of data, including neuroimaging, clinical data, genomics data, proteomics data, and other data. So this was our big data opportunity where we thought it would be a good idea to collect data across all the programs, across all the sites, put it in one place so that we have an opportunity to look for commonalities and mechanisms across the different disorders and within disorders. So this is what BrainCODE allows us to do. It's an extensible open access informatics platform, and it manages the acquisition and storage of multidimensional data collected from patients with a variety of brain disorders. These are the core principles behind BrainCODE. It is open access, so data holdings become available to researchers globally once access conditions are satisfied. Security has been a critical component from the start. We adhere to the high standards of privacy and security, and we have been designated Privacy by Design ambassadors by the Information Privacy Commissioner of Ontario. We have built extensive policy framework around BrainCODE, and we are about to post our next version of our governance policies. Infrastructure is critical. We have built it such that it is extensible, which means different types of data can be incorporated, and it can be expanded to allow for new types of data. Standardization is what we're talking about today, common data elements. These are measures that are common across, within disorders and then across disorders. And this allows us to standardize to a certain extent. There's other things that are going on standardization, but common data elements is one component. Federation is a core principle as well. We are hoping to federate or link with existing databases to augment our data set and allow for richer analytics. Health impact is critical to everything we do at OBI, and here through BrainCODE we are hoping for amplified research outcomes. So an example of this is linking with health administration data, such as organizations like ICIS, and allowing for curiosity and hypothesis-driven approaches. Expertise, we've been working with groups of experts around different components of BrainCODE. We have an international advisory committee, and we have the Indoc Consortium, and Anthony Vaccarino is part of this consortium, that are building BrainCODE. So this is what it looks like. The Government of Ontario funds the Ontario Brain Institute. We fund the integrated discovery programs, which produce the data. The data goes into BrainCODE. BrainCODE may federate with existing databases, and the data set becomes available to the international research community. This is a list of our international advisory committee. We have experts from the US, Europe, and local experts as well, and they have been critical in helping us build our vision and ensuring that we are keeping up with international standards and leading the way. This is a schematic of the Indoc Consortium. led by the Ontario Cancer Biomarker Network. They are designing the molecular biomarker management system and the sort of the back end of the platform and the front end of the platform. So another member of the consortium is the Electronic Health Information Laboratory. This group is designing the security processes and the de-identification and encryption tools being used on BrainCODE's data. The Rotman Research Institute is developing the imaging workflow for BrainCODE, and the data that you will be producing and sending to BrainCODE will be hosted at the High Performance Computing Virtual Laboratory, which is in Kingston, Ontario. So at this point, I'm going to pass it over to Anthony, who is going to talk about common data elements, and we are going to open this up for questions once he's done. Thank you.
Thank you, Shiva. We're going to move on now to basically an overview of the Common Data Elements Initiative of BrainCODE and the Ontario Brain Institute, including a background as to why the CDs are relevant. The process that we use in developing the CDs is including a Delphi consensus methodology that engaged all the researchers and obtained feedback. The final demographic and critical CDs that were developed and have discussion around those. We're also going to have some discussion around the electronic data capture, sort of the methodology we're using for that in terms of being able to collect the data electronically rather than by pen and paper, and also the implementation of the CDs. And then we're going to open up to questions. Hopefully during this webinar, some of the questions will be answered, but there are other questions that are relevant. Please, we'll have discussions around those. Just to give an example of the common data elements, there are a number of different programs that are involved in the BrainCODE platform, programs around autism, depression, neurodegeneration, and so on. One of the questions this allows us to do is sort of look across these different therapeutic areas. For example, if you look at depression and neurodegeneration, we can talk about things like fatigue and apathy as being sort of common symptoms across these two different therapeutic areas. Also, if we look at depression and addictions, we find things like worthlessness, sadness, helplessness are also things that are shared across these different diseases and disease areas. This really allows us to sort of look at the common symptoms across these different areas and develop different models and sort of understanding the common mechanisms here. For example, fatigue and apathy these are common mechanisms across these different therapeutic areas. But more importantly, in terms of common data elements, we've got to find ways to measure these things in a consistent manner. And this is sort of the basis of the Common Data Elements Initiative of the BrainCODE. For common data elements, we do need efficient comparison of data that can only be done when data is available in a homogeneous format. So an example, we're comparing apples to apples. For common data elements, we're measuring, these are measures that are collected consistently within and across all ID programs. For example, data elements referred to as, for example, age is recorded as a day, month, and year. Clinical scales, for example, the QIDS, specific version assessing depression. We're working around a NINDS CD framework. For example, looking at core CDEs. This is consensus-driven, for example, demographic and clinical domains. We're also looking at disease-specific core CDEs. These will be driven by the projects themselves. Moving on to the results and the process that was used. In developing the BrainCODE CDEs, we use the Delphi consensus process. This is an iterative survey process in which we query the different programs and ask them sort of feedback on various things that are being measured. These researchers go online. They have a survey that's hosted on BrainCODE, and they rate the importance of it and so on from these surveys. These results are then presented back to the researchers for additional input. And the idea here is really have this iterative process where we query the researchers in terms of what they think is important, present the information back to them, and then come up with a consensus in terms of what they think should be measured and how these things should be measured, and so on and so on. For the demographic CDs, these are the surveys and workshops that we had. In Survey 1, there was the identification of key demographic elements. In this, we had participants from all the different programs, from the 7 different programs, and highlighting the 11 different demographic variables that we collected. There were 36 that were sent out and 22 responses. This data was then collected and presented back to the survey. second in a follow-up survey to get more information and clarification on the demographic CDEs. These results are then presented at a clinical CDE workshop, and then the results were discussed there and presented to the researchers. If we go through step by step in terms of demographic CDEs, in terms of the process, we started off with a demographic clinical variable catalog. This catalog showed what was collected in terms of demographic variables across all the different programs. And also programs that were related to BrainCODE include the National Institutes of Neurological Disease and Stroke and the Ontario Health Study. The source of this was from the data dictionaries, study protocols, and also through interactions with the researchers themselves. Following vetting of the demographic variable catalog, we developed a recommended demographic variables that should be collected across all different programs. This was presented in the first Delphi survey, in which the ID researchers were asked for their opinion, recommendations, in hopes of achieving some sort of consensus on what should be collected. We started off with 11 different variables in this, including things like sex, date of birth, handedness, and so on. Following the first stage Delphi survey, these results are then presented back, and what we found there is that there were certain things that researchers felt were not relevant to collect, and we moved on to have 5 different demographic variables that should be collected. This included sex, date of birth, handedness, ethnicity, and social economic status. As a result, we had the final demographic core CDEs, and these are ones that should be collected across all the different programs within BrainCODE, and they're also harmonized with programs outside of BrainCODE, things like the National Institutes of Neurological Disease and Stroke and the Ontario Health Study. And again, the final BrainCODE demographic CDEs were sex, date of birth, handedness, ethnicity, and social economic status. Another thing that had to be considered in terms of survey results is really looking at the goals of BrainCODE and also highlighting the goals of the actual programs themselves. So when we ask these questions, we ask not only how these things would be relevant to the goals of BrainCODE, but how are they relevant to the programs themselves for that. So for example, things like date of birth, although that might have been seen as being very relevant to the goals of the BrainCODE in collecting full date of birth, including month, day, and year, it was when you actually asked the researchers themselves how it was important, there were some distinctions between either childhood programs or adult programs in terms of the importance of these variables. Within the clinical CDEs, the surveys and workshops included 3 different surveys in terms of the iterations for the Delphi surveys. In the first survey, the clinical CDs were identified, again, based on the data dictionaries. These were presented at a clinical CD workshop that occurred back in February. And the idea was to have discussion around the type of domains that should be assessed within the clinical CDEs. At that workshop, there's agreement that comorbidity, depression, anxiety, sleep, quality of life, and activities of daily living would be domains that should be assessed across all the different programs. As the next step, once you've identified the domains, the next step was to identify a common clinical outcome that should be used to assess these clinical domains. This was done in a two-stage Delphi survey process, in which the first one we identified the sort of a set of clinical outcomes can be used, and these were presented again back to the researchers in a follow-up survey to identify specifically which outcomes should be assessed for that. And again, just reminding that this is engaging the researchers, and this was sent out to all the researchers in the groups of researchers from all the different programs to get their input. And again, if we look at the process, it's a similar process that was followed within the demographic CDEs, in which first a clinical variables catalog was developed. And again, these are the variables that are being collected across all the programs. There were identification of key clinical variables based on the surveys and also within the workshop of the type of domains that should be assessed, including things like comorbidity, depression, anxiety, sleep, quality of life, and activities of daily living. And then following a second stage survey, it was narrowed down to comorbidity, depression, anxiety, sleep, quality of life, and activities of daily living that should be assessed moving forward. The next step was to identify the actual outcome measures that should be used to assess these clinical domains. And we're presenting that data as well in terms of the actual outcome measures that are used across different programs. These are the final BrainCODE CDs, again, based on the Delphi consensus methodology. There's different types of scales that we're using. There's patient-reported outcomes and also ones that are collected by the clinicians. The ones that are highlighted in blue here are the patient-reported outcomes. These are ones that can be collected by the patients themselves, that can be either done by pen and paper or through how we'll be discussing in a moment in terms of electronic data capture. Within the adults, the scales that were recommended are the Behavioral Symptoms Inventory, the Hue-Qual-Bref, which is a quality of life scale, the Sheehan Disability Scale for activities of daily living, QIDS, the GAD-7, and the PSQI for assessing sleep. And again, these scales take about 5 to 10 minutes to complete each one of them, done by the patients themselves, and we'll also be collecting medical history on the patients as a way of looking at physical comorbidities. Within the childhood and adolescent programs, there's a different set of scales that have been recommended. For quality of life within children, it's the Kindle-R, the RCADS for assessing depression, anxiety, the CSHQ for assessing sleep, and again, medical history for assessing comorbid physical symptoms. Within the adolescent population, again, we have the Kindle-R, the RCADS or the QIDS, or GAD-7 for assessing depression, anxiety. And again, depending on the program, we'd have to work with that to see within the adolescents whether we use the childhood scale or we use the adult scale for that. The PSQI for assessing sleep, and also, again, medical history for comorbidities. And again, with the exception of the medical history, these are all patient-reported outcomes. And we can discuss how to implement those, but one possibility would be to do these things electronically. Either the patient can do it on their own or they can do it within the clinic on a visit, depending on the protocol of the study. Moving on now to electronic data capture using the BrainCODE Portal. Many of you have seen this, and a few people do have accounts of this where they can log on to it. This is the BrainCODE Portal and sort of the point of entry within the BrainCODE for entering data within BrainCODE. There's a welcome screen that discusses BrainCODE, and along the side here you can see various things that can be accessed within BrainCODE. For example, you can see that within each of the programs, the ID programs, there's an actual overview description that is available to the public. So this is sort of a high-level view of what the programs are collecting. There's also a discussion forum for the programs. So a number of people have already been signing on to this to include discussions across their programs that they can discuss with BrainCODE as also within their programs themselves. There's a file structure for allowing files to be uploaded into the BrainCODE Portal. And sort of more importantly in terms of the discussion around this webinar are some of the BrainCODE tools that are available. So in terms of open electronic data capture, we have things like Open Clinica, Redcap, and Lyme Survey. And these are things that you can actually go onto the BrainCODE Portal, you log on to it, and you begin to enter data electronically. Now moving on to what are called electronic case report forms. Sort of what are these ECRFs, who's going to need them, and how are we going to sort of implement these things into the studies. Basically, electronic case report forms are what we're calling e-studies. Traditionally, the way clinical trials would be run is that they're done through pen and paper. So their sites are given various binders that have the various CRS or case report forms or patient-reported outcomes within these binders, and allows things that can be like transcription errors. There could be also in terms of lengthy time of entering the data. It's just not the most efficient way of doing things. What we're moving towards in terms of for BrainCODE are using what are called electronic data capture, or what we're calling e-studies. And this is a way of sort of replacing the binders and the paper forms with electronic forms. So simply at this point, what you do is simply log on to the BrainCODE Portal using whatever data management system you were using at that point, whether it be Open Clinica, Lyme Survey, or Redcap, and click on the actual CRF, and the CRF will become available. So this is going to replace the paper report forms and allow us to sort of have pure electronic data capture. And we're calling these e-studies because what we're looking at here is an ECRF is an actual electronic form of a case report form. An e-study is a number of case report forms that are made into a study based on the number of visits that you're using and different types of case report forms that are applied. And we've been developing this for the different programs, including CanBind, the depression program, and also within EPLINK in terms of that epilepsy program. Just a quick overview of the electronic data capture workflow, and this would be, for example, of patient-reported outcomes. And again, these are ones that the patients themselves would fill out. It can be done either electronically or in pen and paper and then transcribed electronically. The preferred method would be option one, would be patients enter data directly electronically into the system. So they would log on to a computer. In this case, we'd be talking about Lyme Survey as a patient-reported outcome tool. So in this case, the EPR, or the electronic patient-reported outcome, is a source document. So it really doesn't have any problems for things like transcription errors and patients given prompts when there's incomplete data. So this would be the preferred way. The patient logs on directly into Lyme Survey, and that goes to the Lyme Survey database as recorded there. And again, this can be done in the clinic, depending on the protocol of the study, or it can be sent home for the patient to log on their own computer at home with various passwords and so on. Another option would be have the patients use the patient-reported outcomes in terms of a paper, and that would be transcribed in the Lyme survey. Again, this might be preferred by some patients who aren't comfortable with computers, but it does lend itself to possibility of transcription errors when you go from the paper patient-reported outcome to the Lyme survey electronic patient-reported outcome. Another thing that, in terms of the sort of common data elements or standardization, is that we're developing subject ID conventions that should be used across all the different programs. For example, the one that we're using here, and that we are really recommending that different sites do use as a common way of identifying the subjects, includes the program, the study, the site, and the subject ID. We'll have a log and a manifest that defines the various different acronyms and so on from that, and the digits and the codes that are used for this. But basically what we're asking is that the sites do use this in terms of identifying a specific subject. And this allows that subject to sort of use that same thing, that same kind of identifier, whether you're talking about clinical data, imaging data, or proteomic data, or molecular data. For example, the program here would be CBN, in this case is the Kanban program, study 1 being the study that's involved, that'd be part of this program, the site where the data was collected, and also the subject number. This is available. We sent out earlier a package to different sites to highlight the implementation of these standards, and you should have records of those. In terms of the implementation, we're doing this really by project basis. So we're really here to help you. We understand that everyone has different sort of protocols that they're following and different needs that they require. So we're really meeting with the programs to find the best way to implement these electronic case report forms and disease studies, and more importantly, these common data elements into the various programs. There's going to be two sort of critical steps in the implementation, and we've done this with some of the programs already as we're moving forward. The first is that there will be required an REB amendment to include these additional variables. And the plan here is that OBI would work with the IDP programs, or the ID programs, to develop basic stock language around this. This would include things like the goals of BrainCODE, the BrainCODE CDs, sort of why they're being implemented, the consensus process that was used to identify the measures, and also the relevance of the disease. So it's really important when you're presenting this stuff to the REBs to really understand as to why this is being relevant and why this is being collected. So why are we collecting depression in children and also in other populations as well? And this would be related things to the goals of BrainCODE, and also really highlight the consensus process was used to identify these measures. The second thing is going to be a bit more of a challenge, but it's going to be done by a project basis, is the integration of the CDs into the ID projects. So the BrainCODE team has already been developing what we're calling, again, these e-studies, development of these ECRFs, and the training that's involved with various programs. So EPLINK, the epilepsy program, CanBind, the depression program, and the neurodegeneration program are all programs that we're moving forward now and implementing these into their programs based on their protocols. There are also going to be programs that might be developing the e-studies, again, these electronic studies on their own, but they should nonetheless really consult with the BrainCODE team to make sure that we're really harmonizing in terms of the common data elements that we feel are important to collect across all the different programs. Another sort of value added with this is that the ECRFs that are being developed as a result of this effort will be available online in the BrainCODE Portal, so they can be integrated into the programs themselves. So we're going to leave it at that. I just want to highlight at this point the slide of the measures that are being taken. Again, so these are the ones through the consensus process and through interactions with the investigators that are now the sort of the final common data elements that we were recommending be collected across different programs in terms of the adult populations, the child populations, and the adolescent populations.
We wanted to leave lots of time for questions. So any kind of questions you have, this is a really good time to ask them.
Hi, this is Elizabeth.
Hi, Elizabeth.
Hi. So I just wanted to clarify. I joined a little bit late, but so for me, for my studies in children, the recommendation would be then that we do these measures in any kids that are recruited into the study?
That's right. So the goal here, again, is that the question, Elizabeth?
That's the question, but
That
if you
is-
just
okay,
then there's a follow-up question. So
Okay,
if the
great.
answer is yes, that's I understand that recommendation,
Okay, great.
Anthony, and that's great. So is there so because those aren't measures that I'm familiar with as an investigator, who are the resources available to me to help me understand how to use those measures and whether they're actually appropriate for my population? Because we can't just kind of randomly, obviously, give the measures to families.
Sure. Early on, this is during the clinical CDE workshop, there are sort of certain criteria we arrived at as a group that would move forward in sort of deciding what these clinical CDEs would be in terms of the measures. One is in terms of domains that we thought were important to collect, and these include things like depression, anxiety, and sleep. Another thing was sort of the types of scales that would be used. There's really a recommendation to use sort of easy-to-use patient-reported outcomes, ones that aren't very time-consuming and don't require a lot of training. So, for example, all the ones that are highlighted in blue, again, are patient-reported outcomes. So for the children's study, which would be relevant to your studies, the Kindle-R was one that was recommended through this consensus process. And again, there's discussion around that sort of in terms of finalizing that should be used to assess quality of life. I believe it's a 6-item scale. The scale itself has a instruction manual on how to administer the scale to the children for that. These should be self-explanatory in that sense for that. Something like the medical history form is a little bit more complicated, so there could be some training around that in terms of administering the medical history form and where the sources should be in terms of getting that information. But again, the goal here was really to have easy-to-use patient-reported outcomes that are valid and also would be assessing these things of importance that were felt to be important across the different programs.
So just to follow up on that, I actually did participate in the process of asking what measures we thought would be appropriate. And because I'm not an expert in pediatric quality of life, for example, I kind of deferred my answer for most of those because I don't actually know which is the most appropriate scale. But I do know enough to know that not every scale is appropriate for every population, and we study a variety of different populations. So I still think that even though it's been selected by experts that I trust and really my colleagues in these projects, I still think that I need to have access to an investigator who's comfortable using those scales to help me to understand how to apply them to my patients and what they would add. So I'm just wondering whether there are investigators, or I would recommend that we identify some investigators for me within EPLink or even within another one, if that person's interested in collaborating, that can be a resource for us to try and understand how to use these.
Yeah. One of the things that was distributed with the package that was sent out, I believe, about like a month ago or so in preparation for the meeting, is the clinical and demographic variables catalog. Within that, you're going to see the actual measures and various aspects of that measure, including the valid population, the population that should be valid to use in, including the age group and the types of population they might be used in for that. So that might be sort of one source to look at in terms of, is this an appropriate scale for my age group? So, for example, the Kindle-R within itself, it has three age groups that could be used for that, but for a 2-year-old, it wouldn't be relevant. Again, assessing things like depression might not be relevant for a young population.
Yeah. I got to say, I don't want training in it because it's not my expertise. What I want is a collaborator who will work to help me to understand. So, for example, I can imagine who at my own institution might be able to help me with that, but I'm just wondering whether BrainCODE has some people with expertise. I
wonder if, and that's a great point, I wonder if this is something that we could do through the portal in terms of a discussion forum.
Yeah.
Really is that, with that suggestion, it might be worth at this point to moving towards a portal, having a separate discussion forum where for the common data elements, that is sort of a source that people could start using. Because like you're saying, there are people who are familiar within the programs, not necessarily your program, but within some of the other programs that are familiar with using a Kindle-R. And that's something that would be a valuable resource for you to be able to collaborate with and refer to. Is that right, Elizabeth?
Yeah, I think I'm reluctant to include something before I understand how it's applicable to my population. And I think, specifically to the populations that I study, many of those children are very disabled or developmentally delayed, and so some of these things don't actually apply. and
Exactly.
it would not be appropriate to submit the families to the measures. So
Exactly.
I need that insight.
Yeah. So as another sort of arm of that is that, as we're implementing these, again, we're meeting logics on a one-to-one basis. And again, these are the ones that sort of generic instruments that are being discussed in terms of adult children and adolescent populations. When you're talking about specific populations, there are some restrictions in terms of how these things are going to be applied. And I think that's something we had to have a discussion with the programs themselves in terms of whether this would be an appropriate to assess in that population. Because if you're talking severely disabled children who, really, first of all, themselves wouldn't be able to fill out these things, which is understandable. There's also proxy versions of these scales where the parent can fill it out. And again, it was felt that, and I think there's general agreement in that in terms of the importance of assessing some of these various domains. So the Kindle-R is a health-related quality of life instrument. And again, if we're looking at sort of functional impact and impact of the disease, some importance in terms of collecting the quality of life scale. There's a question here from TG. Some of our studies have retrospective cohorts. How are we going to obtain the data if the study is retrospective? Yeah, so there's one of two ways to proceed with that. In terms of retrospective data, you'd either have to reconsent the patients in order to collect this data. And again, there's probably like avenues to be able to do this in a sort of a very streamlined way. Once you do reconsent, because you didn't have permission to collect this data, it could be sent to them as a link to fill out online for that. The other thing that's something that is a restriction. I mean, for some retrospective data, we're not going to be able to collect these things. So these are really made for prospectively moving forward as we're collecting data, that we want the groups to be able to collect this data prospectively. But if there is a way to collect this retrospectively, that would also be a possibility.
This is Mac Burnham. Just a clarification of what we arrived at last Saturday, simply that we certainly want this battery of clinical tests to go forward, and we'll do our best with it. We will have to get it through our REBs, which we'll try to do. But is it clearly understood that we offer these to the patients, but that the patients do not have to take them if they don't want to?
Well, I think that's with any scale within an informed consent form, they have the right to not participate in something. I mean, we really are encouraging. If we just sort of take a step back in terms of the goals of BrainCODE, where there are a number of different ID programs that we're really trying to understand across these different disease states, things that might be in common in terms of common mechanisms. I mean, there is that sort of rationale to say that this is something that should be done to a certain extent. But again, on the other side of it, this is a patient burden, and it's also a clinician burden. It's sort of an additional measures that are being included in the studies for that, and that also has to be weighed as well for that. But again, I mean, obviously you can't force a patient to fill out a questionnaire.
It's from Chrissy Doyle Thomas, and she says, as per your guidelines, the CSHQ is suitable for children 4 to 12 years, and the PSQI is suitable for children 18 to 65 years. So what sleep measure should be used for participants 13 to 17? Cover that gap.
Mm-hmm.
That's a good question.
That is a good question.
Yeah, PSQI is good for adolescents as well, ages 13 and above.
I have a quick question.
Yeah.
In terms of the REB for the new variables, when will we expect to hear back from the OBI in terms of incorporating any changes to our current REBs?
So as a next step, you obviously haven't submitted the REB amendment yet.
No.
So which program is this?
The Transitional Epilepsy Program.
Has there been any REB submitted at this point?
Yeah, there has been.
Okay. So now what we're talking about then is an amendment to the REB.
Yeah.
Exactly. So as a next step, I can contact you, and we can sort of discuss how to best move forward with that.
Okay.
Which basically we're developing stock language. I think one of the concerns is sort of one of the things that would be sort of to our advantage to do at this point is really have some good stock language for the REBs around the CDEs, because we're presenting this to REBs saying that we want to start collecting this variable within this population, and really the relevance is important to the REBs as to why you're adding this additional burden to the to the patient.
Yeah.
So having wording again around the BrainCODE goals, why it's important in terms of understanding across diseases, and also in terms of the consensus process that was used in developing these CDEs, is that there was this level of agreement across the different programs for that. So that's something that we should move on sort of as quick as possible.
Is that what you're asking for? You want the stock language, or is there?
Yeah, the language in general, yes.
Okay, yeah, Luca and Anthony will be working on that, and we will send it to you.
Perfect, thank you.
Hi, it's Kat here from the EPLINK program. Is the BSI measure that's to be administered the 53-item scale or the 18-item scale?
It's the 53-item scale.
Okay.
So the BSI, although it's 53 items, is a short version of the SCL90 for that. So yeah, it's the BSI. It takes about 5 to 10 minutes to complete. It's a checklist. Yes, sir.
I have a question, actually. What's for POND and CPNet that already have their ECRFs through Redcap? What's the best way to integrate these with their setup already?
Well, so both they're using POND and Redcap, and so they're using data management systems that are supported right now by BrainCODE for that. So it's really a question of just basically developing ECRFs around that with the programs to implement those within their programs. Some of these have already been developed. They're going to be available in the portal. For example, the QUIDS and the GAT7 and the Sheehan are already ECRFs that have been developed, and those can be incorporated, adapted how they need to be adapted within the Redcap system. But what's being recommended there for the ones that are already developing their own databases and have their databases is that there's that communication with the BrainCODE team to make sure that we are using the same version and so on from the CDEs.
All right, we've got another question from CG. This is again on the topic of retrospective cohorts. For our REB application, we are going to have an exemption to obtain consent from patients, since this is a big number of patients in the retrospective cohort. If we have to resubmit REB just to obtain consent to the BrainCODE, this will be a big amendment. I have about 70 patients in the retrospective cohort, so doing the BrainCODE for these patients will be a huge undertaking.
Yeah, I mean, so this is really designed for pro studies. I mean, so moving forward, these are the ones that we'd want to be including for that. And there's a number of reasons for that, is that when we're talking about common data elements and standardization, it's not simply the scale itself, but when the actual stuff is being collected at that point. So we are recommending that these measures be collected at baseline before there are any kind of intervention, so we do get that sort of clean measure within that population of these outcome measures. Now, that's going to be virtually impossible to do with a retrospective study. You'll be collecting this at sort of at a later date. Again, it can be information that's important to collect, but I wouldn't. Obviously, it's just not going to apply to your retrospective study to be able to go back and reconsent these patients for that. One thing we are moving forward with, or moving towards within the BrainCODE portal, is to have access for patients to be able to log on and fill out these things on their own, or collect information from a wider range of patients for that in terms of these common data elements. So that might be sort of a source that these patients can, if we want to collect data on these patients, to be able to do it through the BrainCODE portal. But again, it's not feasible, I think, to reconsent these patients retrospectively and try to collect this data.
It's Kat here again from the EPLINK program. A couple of the PIs asked me this question, and I wasn't sure how to answer it. Regarding the Sheehan disability scale, it says that the patient should measure or report their disability and impairment. So, for example, someone with epilepsy who might have a physical disability with memory problems, should they be rating their epilepsy, their disability, their memory problems all together or separately? How should that be answered?
Yeah, and again, these the goal here was, again, is one of the goals when we were developing the BrainCODE clinical CDs specifically, is to have sort of generic versions, which is not always easy to do because you're talking about special populations for that. So the Sheehan disability scale was really designed mainly for mood disorders and looking at disability as a result of the mood disorders for that. Now, we're dealing with an epileptic population. I mean, are they answering the question in terms of disability related to the epilepsy or any kind of mood issues they might have for that, which really becomes relevant at that point because it could be sort of the data. It looks like the data at the end, you have an outcome measure, but what's causing that it would be entirely different within those two populations. So here, the Sheehan disability scale might not be a relevant scale to administer in this population for that. And again, that's something I think we should meet as you're developing these databases and these e-studies and these ECRFs, again, to see what is relevant for that study and what's not relevant for that study. Because again, here we're talking to adults in terms of a sort of a generic population, but when we start talking about specific populations, there are going to be some limitations of these scales for assessing things in those populations. The same thing would happen with the geriatric population as well, is that certain things that really aren't relevant for that population. I think that's sort of a take-home measure for a take-home thing for all the programs is that, we're talking here in terms of generic terms, but once we start talking about specific populations, there are going to be some limitations for that. So we've tried to collect scales that do apply to sort of generically to all populations, but there are going to be some restrictions. One thing that you can do too, again, that clinical variable and demographic variable catalog highlights, again, the studies that these things have been valid in and that they're appropriate for in terms of the age groups and so on from that.
It's Kathleen.
Hey, Kathleen.
Hey. Just a question. What about our prospective studies for whom we've already started collecting patient data on? Are we going to have to go back and reconsent and then collect the data?
Well, there's two things there. So we're talking here, but you'd be talking about sort of an ongoing study?
Yeah.
Right. So there's going to be, again, and this is kind of similar to the retrospective issues there. One thing that would be done sort of immediately, sort of in terms of moving forward, would be an REB amendment. And this would be an amendment that's saying that these are new clinical variables that would be collected in this study, and the informed consent form would have to, the new informed consent form would have to reflect that. So any patients that are being collected de novo, that is new data being collected on these patients, these common data elements would be collected. Again, now going back retrospectively to these patients, again, that's a challenge that is going to be around having to reconsent the patients for that. And you probably wouldn't have to do that. This would be something we'd really want to be collecting sort of prospectively at that point and not have the additional burden of having to reconsent the patients to collect the data. Another question is here, do we have to get permission licensing to use these tests? Some of the tests do require permission and licensing. For example, the HUQUAL, the PSQI are two scales that don't have a fee associated with it, but do have permission that's being required. We're doing that on our end. So OBI is, and I think we've already submitted the applications to these organizations to have permission to use these various scales. So the time that these things will be implemented, there's the majority of these, again, that was one of the criteria we tried to keep, is that they do be freely available to researchers to use. But there are some that do require permission. And it's mainly just copyright permission to make sure that the scale is not being altered in any form for that. So again, these scales will be available at the time that they are implemented, and all the licensing agreements and permissions will be in place.
Any more questions?
So as a next step, and we've done this with some of the programs, because one of the other challenges or things that we haven't addressed here is that different programs are at different stages of development for that. Some have already initiated the studies, others have not. We can see from the webinar today, some are questioning whether they have to collect retrospective data. We'll be contacting each of the programs to sort of look at a way forward to best start implementing these CDs into the programs. And we're thinking that the point of contact will probably be the program managers.
Great. Well, thank you, everyone, for joining us. If there's any other questions, there's always the opportunity to email and ask us. You can ask Anthony. You can ask the BrainCODE team at OBI. Also, Krista and Joanna can answer your questions. So if there's no other questions, we'll close the webinar. Great. Thank you very much.